Hi, welcome to the CPIC Resources for Services Cognitive Behavioral Therapy sessions. My name is Judy Ho. I'm a clinical psychologist on the project, and today I'll be introducing you to session 1 of 4 for the cognitive behavioral therapy information that we have here. Today's purpose is to introduce you to the resources available to therapists and administrators as part of the CPIC project. Some of the things that we will be discussing today are to look at the CPIC project and available CPIC support resources for treating depression in the community, and to learn about the 5 steps of assessment for depression and how to implement this with new patients. Some of the questions I'd like you to think about before we start the session are, how many clients do you see at your agency that report depressive symptoms? How often do you usually screen clients with depression? Do you have a routine procedure for how you screen clients with depression? And how do you usually treat clients with depression? Finally, have you heard of cognitive behavioral therapy? And have you used it in your practice? I wanted to take some time to give you a quick overview of the CPIC project. Community Partners in Care, or CPIC, is a partnership of community and academic members that compare 2 ways of improving depression care, using either the community engagement model or the technical assistance, or also what's known as the resource for services model. The collaborative care model is a team-based approach to managing chronic health problems such as depression. And there are multiple roles in this CC model, including the care manager, therapists like you, and primary care providers or psychiatrists. Please find a copy of the Therapist Guidebook and Therapist Resources on the CPIC website, and we will be touching on main points from this guidebook on today's session, as well as future CBT sessions. In this guidebook, we have some suggested goals for the CPIC therapist that's interested in using cognitive behavioral therapy, and there are 4 goals. The first one is to support clients as co-managers of their care. So instead of feeling like you're at one level and the client is at a different level than you, you're working together as a team so that you can co-manage their mental health problems together. The second goal is to assess and monitor client symptoms and progress. The third goal is to support coordination of care. Many times, clients will have different people taking care of them, such as their primary care physician, such as a social worker, and your job is to try to support that coordination of care as much as possible so that you can help the client get the best care they need. And finally, the 4th goal is to teach client cognitive behavioral techniques to address depression. And we'll be talking about that on today's call briefly and in subsequent calls as well. There are some suggested assessment steps for treating clients with depressive symptoms. The steps we will talk about today is one way to systematically evaluate people with symptoms of depression. We're going to be referring to forms in the CPIC Therapist Toolkit, and you can also find this on the CPIC website. And we can provide them to you as well by hard copy if you go ahead and request it through the office. And this is going to be helpful for you during the implementation of the 5 assessment steps. Step 1, screening for depression using the PHQ. So why should you search for depression? Well, clinical depression is very common in the primary care clients. It's about 5 to 10% of all primary care clients, and it's often unrecognized by clients, families, or physicians. Successful treatment shortens the course of depression and prevents recurrence. And CPIC's goal is to find, evaluate, and treat clients with current clinical depression. So that includes major depression, dysthymia, bipolar disorder, or manic depressive disorder. CPIC is directed toward using the primary care setting and focuses on clients with major depression and dysthymia. And usually what we do is we provide referral for bipolar disorder, which is sort of in a specialized category of their own. So in the first step, what you want to do is search for clients who are likely to have clinical depression. So at this point, you're not making a clinical diagnosis using the DSM-4. You're just screening for people who have some severe or significant problems with depression. And detecting depression in primary care practices can be very difficult. Sometimes even the most experienced providers will miss depression in clients if he or she does not routinely assess clients for key symptoms. The PHQ is a good start for detecting clients most at risk for having major depression. So I want to talk a little bit about the PHQ, which is also known as the Client Health Questionnaire. The PHQ is a 9-item self-rating scale. We recommend using this very short and easily administered questionnaire at the intake, as well as throughout the course of treatment to track the client's depression. The scoring of this PHQ is very easy. 0 to 4 means that they have none or minimal depression. A score of 5 to 9 means that they have mild depression. 10 to 19 means that they have moderate depression. And 20 to 27 would indicate that they have severe depression. So at the step 1, we have a checkpoint. If the client does not have current symptoms of depression or dysthymia, then the client doesn't require intervention for depressive symptoms. If that's the case, no further evaluation is needed at this time. If client does have current signs of symptoms or depression or dysthymia, which means that they have a PHQ that's equal to or larger than the score of 5, or they're currently in treatment for depression with a provider, you would proceed to step 2 of this assessment process. Step 2, evaluate diagnostically for depression and comorbidities. So at this point, you are going to try to make a diagnosis for depression. If they are screening positive for the PHQ, which means that they have a score of 5 or greater, you're going to move on to the second step. At the same time, you're going to be looking for some common other coexisting disorders that may be important in their treatment. Diagnoses made among clients who have symptoms of depression or dysthymia may include people with bad moods that pass. That means that it's a very transitional state and they may not even require intervention. There are also things such as bereavement or grief reactions. A lot of these times, these individuals will need some therapy, but again, it's also a transitional phase. There's also adjustment reactions, another type of transitional problem with depression. Then we move into the depression that really requires intervention to get better, and that includes minor depression, major depression, and dysthymia. I have here the diagnostic criteria for major depression, and this is taken right out of the DSM-4. And as you can see, major depression is more than just a low mood. It's a symptom defined by at least 5 of the following 9 symptoms. These symptoms have to be present nearly every day for 2 weeks or longer, and one of the symptoms has to be number 1 or number 2 below, which is 1, depressive mood, or 2, loss of interest or pleasure. I would recommend that you go ahead and run this list through with your clients if they are screening positive for the PHQ to see if they actually meet diagnostic criteria for major depression. And here I have the diagnostic criteria for dysthymia. Dysthymia is characterized by an overwhelming yet chronic state of depression, exhibited by a depressed mood for most days, for more days than not, for at least 2 years. This individual must not have gone for more than 2 months without experiencing 2 or more of the following symptoms. And so again, I would recommend going ahead and asking the client these questions on this list below and seeing how they respond to see if they actually meet diagnostic criteria for dysthymia. So now here we are at the step 2 checkpoint. At step 2 first checkpoint, we have if client meets criteria for current major depression or dysthymia, you would document their symptoms and continue the evaluation from here. If client does not meet criteria for current major depression or dysthymia, you would note that as well and continue the evaluation. So we're still in step 2, and we're now going to be looking at comorbid or other clinical conditions that may co-occur with depression or dysthymia. So something that you might want to think about is medical illnesses that can cause depression. Sometimes clients' depression can be linked to a severe medical illness they may have, and so that would be important to assess. It's also important to assess for current or past substance abuse. And as part of CPIC, we have several measures for you to use to look at current or past substance abuse and alcohol abuse. We have the CAGE questionnaire, which is 4 questions, and you can see it here on this slide. And the 4 questions can be substituted on the last word to be used for drugs instead. So as you see right here, for example, the first question says, do you ever feel the need to cut down on your drinking? And you can actually substitute the word drinking with, do you ever feel the need to cut down on your drug use? So you can use it for both alcohol use as well as drug use. And this questionnaire is very simple. It's only 4 questions. And if the client has 1 or more positive responses on this CAGE questionnaire, that would suggest that the client likely has an alcohol abuse problem. So that would be a point for which you to probe further using the DSM criteria for alcohol abuse or alcohol tolerance.